Welcome back. We are now going to discuss about the atrial flutter. What is atrial flutter? Atrial flutter basically is sort of a atrial tachycardia. It's atrial tachycardia that results from a macro-reentrant loop. Macro-reentrant, which means there is a loop of the excitation potential that is formed, and that loop moves on again and again in a circular path and causes the atria to um, excite again and again, and therefore it produces a rapid but regular atrial excitation. And this point is the difference between the atrial flutter and the atrial fibrillation, which is an important thing to understand. However, an atrial flutter may also get converted to the atrial fibrillation, and the difference of both we are going to see in the end of this lecture. Okay. Now, atrial flutter is the rapid regular atrial excitation, as I've already stated, and it is a type of supraventricular tachycardia. Supra means above and ventricular means above ventricle, so supraventricular tachycardia because it is originating above the ventricles. Then the other supraventricular tachycardias to be aware of are Wolff-Parkinson-White syndrome, in which there is an accessory bundle of Kent, and that causes the increased pre-excitation of the ventricles, and there is a tachyarrhythmias are there. Now in the atrial fibrillation, I've already discussed the atrial fibrillation, and the atria sort of quivers due to some ectopic foci. In AVRT, which is the atrioventricular reentrant tachycardia, it's enough to know that here that there is some reentrant loop in the AV circuit, while AVN means uh, atrioventricular nodal reentrant tachycardia, and here again it's enough to know that the loop is inside the AV node. The reentrant loop is inside the AV node. Okay. Now, what's the mechanism behind the atrial flutter? Now, atrial flutter basically are of two types. The type 1 atrial flutter, which is also called the typical, and that involves the cavotricuspid isthmus. And the type 2 one, which is atypical and doesn't involve the cavotricuspid isthmus. So, what is the idea behind the cavotricuspid isthmus? We need to know it first. Now, let's say you have your heart. Okay, this is your heart, and we have over here is our right atrium. Then we have the tricuspid valve. Now let us zoom in over here, and let's say you are imagining your eye over here and viewing the right atria from the bottom. And whenever we look at from the bottom of the atria, you would see a uh, circular shape, and over here in the circular shape you would classically see a counterclockwise direction. So counterclockwise direction would be in this way, and if I'm saying we have a counterclockwise direction, that is in the reentrant loop. Okay, now let me draw the vessels over here, which the openings of the vessel. This is the superior vena cava, and this one would be the coronary sinus. Then over here is the inferior vena cava opening. Now if this is a loop, okay, this is a loop, and over here in this part, this particular segment has a slow conducting property, and this because of this slow conducting property, what happens is that this part remains in the refractory period, and the other part of the loop is out of refractory. So till that time this part remains in the refractory period, while the other part of the loop are out of refractory. They would again conduct, and the loop would again, I mean the circuit would loop on itself, and that would cause the reentrant circuits to form. So this area is called as cavotricuspid isthmus. Okay, this area is called cavotricuspid isthmus, and that is the important thing in the typical atrial flutter, the type 1 atrial flutter. Okay, and that's what I have also stated, that there is circus movement that is continuous, self-perpetuating in a circular path, and in the type 1 that path is in around the cavotricuspid isthmus. Okay, now only this much is not important for the atrial flutter to develop, because everyone would have the cavotricuspid isthmus and this kind of property is there. But uh, some other factors are also necessary, which we are going to see, like the ischemic heart disease or any other problem that causes the different properties of the different electrical properties of the atrial cells and make them contract at different times and forming a reentrant loop. Okay, let's see the types of the atrial flutter. Typical atrial flutter, I have already explained, around the Cavotricuspid Isthmus pathway, and obviously it is around the tricuspid valve, so it is in the atrium, and this is the most common type of the atrial flutter which is present amongst the patients. Now there is also atypical atrial flutter that has reentrant loops around the in the left atrium, okay, and it is obviously Cavotricuspid is independent. As I've already stated, around the Cavotricuspid Isthmus pathway, classically we have a counterclockwise direction movement. Counterclockwise direction. Okay, so this thing is to be kept in mind. Let me reinforce that thing again. We have this our loop from taken from zoomed in from the tricuspid valve. Here we have the superior vena cava. Here we have the coronary sinus, and here we have the inferior vena cava. Now this is the loop which is formed, and in this loop we have this particular area which is called the Cavotricuspid Isthmus, which has slow propagating property, and because of this remains in refractory while the other part of the loop still conducts, and this causes the circuit to loop on itself again and again and in a counterclockwise direction. So this causes the atrial flutter to occur because of formation of a reentrant circus movement of the action potential. Okay. Now, what are the ECG findings in the atrial flutter? Now, typically we see the atrial flutter in the lead 2 and lead V1. And as in case of the atrial fibrillation, we also have the F waves over here in the atrial flutter. So how are we going to differentiate between them? Actually, we cannot differentiate them much, but appearance in the atrial flutter we say is like a sawtooth, just like this. So this is a sawtooth like appearance, and obviously the P waves are absent. Instead we have F waves, which are the flutter waves. Now why I'm also saying these F waves and in the atrial fibrillation also F waves is because these F waves kind of, we can think that in atrial fibrillation also there is tachycardia, in atrial flutter also there is tachycardia, and both are because of the atria. And in the atrial fibrillation the rate is faster, while in atrial flutter the rate is comparatively slower. In atrial flutter they are regular, while in atrial fibrillation the rhythm is irregular. But still there can be conversion of the atrial flutter to fibrillation, and in this way you can remember that F waves are seen in both of the atrial flutter and atrial fibrillation. Now, important thing, as I've already stated, the rhythm is regular in case of the atrial flutter, while it is irregular in case of the atrial fibrillation. Important, high to know. Now the rate, yes, the rate is 250 to 300 beats per minute, while in the atrial fibrillation, can you recall, it's around 400 to 600 beats per minute, very high. Okay, so these are the important ECG features in the atrial flutter. Another high yield principle to be aware of is about the ventricular rate. Now, ventricular rate depends upon the AV conduction ratio. Now, AV node, as we know, it acts as a checkpoint and has a compensatory pause of 300 milliseconds. Now, what is happening in the atrial flutter is that, let's say the atria beating at a 300 beats per minute. So what would be the next beat of the atria coming? It would be in about, we can see by dividing it by 300. Then this would be around 200. So in the 200 milliseconds, the next atrial beat would come. So let's imagine we have this P wave which is coming, followed by the QRS complex. Now what would happen is that if this is the P wave, now we have our AV node pause, which is about 300 milliseconds. But our next atria beat is going to come in 200 milliseconds. So we would see a atrial beat. Let me draw it with the other color. So we would see a atrial beat. This blue one is the atrial beat, but we would see no QRS complex because of the pause. So let me draw again. This one is our P wave, followed by QRS complex, then again a P wave, then with pause. Because of the pause there is no QRS complex. So can you see what is happening? We are seeing a 2-to-1 ratio. There are two P waves but only one QRS complex. So this is a 2:1 ratio of the in the atrial flutter. So like this we plot the ratios. Now let's imagine the atria are beating at around 450 beats per minute. Okay, so what would be the milliseconds for the next beat? Would be about 130. Okay, 130 milliseconds. And so let us draw it again. We have our P wave followed by our nice QRS complex. Now what is happening is that again we have our AV pause, that is about 300 milliseconds, but the atria beats in around 130 second. So what is happening that this has this is occurred. Now next would occur at around 260. Okay, so after, sorry, that would occur about at the 130. So next P wave is formed, and thereafter again one P wave will be formed, and that would be after 260. So this is 130 and 260. So two P waves more are formed without a QRS complex, and that's because we have no conduction occurring through the AV node because of the compensatory pause. So can you imagine what is happening? Let me draw it again. We have P wave, then we have our QRS complex, then again a P wave, then again a P wave, and then following the same. So 1, 2, 3, 3 is to 1. Okay, now this is 3:1 ratio. So very high to be aware of. How we do it is that we know the when the next atrial beat is going to come, and then we compare it with the AV pause. Okay, so this is the concept behind the ratios of the ventricular rate, that is 2:1, 3:1. Usually the ratios are even, but odd ratio can be there. Okay, now the basic difference behind the atrial flutter and the fibrillation, yes, we have already discussed in the whole lecture, is that the rate of the atrial flutter is slower and it is more regular. And the main pathology is the reentrant circuit problem. While in the atrial fibrillation, it is faster, around 400 to 600, while 350 to 450 in atrial flutter. And the problem in the atrial fibrillation is ectopic foci, and the rhythm is usually irregular. Okay. Now the treatment for the atrial flutter would be the cardioversion. What is cardioversion? The cardioversion is that we depolarize all the atrial cells at once, so that they depolarize in a regular fashion, or in the at all at once, and this would prevent the reentrant loop to form. Or either we can also destroy the Cavotricuspid Isthmus pathway, and this is useful if we have type 1 atrial flutter problem. Then we need to maintain the rate, so we are using antiarrhythmic drugs like amiodarone and prosenamide, ibutylide, and flecainide. Then we have also anticoagulants, and yes, why we use anticoagulants, this the same principle as in case of the atrial fibrillation, is that because the atria are contracting at a very fast rate, so the efficient contraction finishes. I mean, there is no efficient contraction, and because of this the blood sort of stagnates in the atria, and this causes the formation, the probability of the clot formation would increase, and therefore that may also form an emboli, or that may also lead to stroke. So we use the vitamin K antagonist, then oral anticoagulants like dabigatran or rivaroxaban, and also we can use the antiplatelet drugs aspirin and clopidogrel to further prevent the thrombus. Okay. Then we also have the drugs to maintain the rate, and also to maintain the atrial, to maintain the, to prevent from the heart failure. And why? Because the atrial flutter is occurring, and we don't know about the ventricular rate, when the ventricular rate may go to 1:1. Now if the ventricular rate goes to 1:1, can you imagine what would happen if the ventricular rate is around 200, 250? Yes, it would increase the chances of the VFib, ventricular fibrillation, and also it may also actually weaken the heart. What is happening whenever we have some sort of a tachycardia, abnormal tachycardia, the heart is actually pumping more than it should, and it comes at a cost of more energy, and slowly and steadily the heart is failing itself because it is not meeting its energy demands. So to prevent the heart failure, we use the rate stabilizers that are the verapamil and beta blocker, that is the metoprolol. Okay. Lastly, let's see the significance of the atrial flutter, where the atrial flutter is important. Atrial flutter is commonly associated with rheumatic valvular diseases after ischemic heart diseases. Why? Because ischemic heart diseases, even the rheumatic valvular diseases, what they cause is they cause damage to the cells of the heart or even the conducting cells, and they may cause the change in the electrical properties such that the one cell is out of refractory and one cell is in the refractory, and they are in the different having different electrical properties, and this would cause the uh, increased probability of formation of the reentrant loop, even associated with the hypertensive states and pulmonary heart diseases. Okay, so with this we have concluded our lecture on the atrial flutter. Hope you liked it. Subs if you loved it. See you in the next one. And do subscribe the channel, guys. It helps me a lot. It gives me motivation to make more of the videos. And to all the subscribers and to new ones, thanks a lot. You're helping me a lot. Thanks a lot. Bye.